Hi, this is Mark Struthers. Today we're not going to talk about the routine ultrasound or the complicated ultrasound. We're going to talk about ultrasound in trauma. Emergency ultrasound is sort of down and dirty. I need to get the answers and I need them now. I don't have time for all the subtle nuances of doing a complete study. I have an emergency to take care of. This is called point of care ultrasound. And it happens in emergency rooms, it happens on EMS trauma sites, and it happens in natural disasters. We take the portable ultrasound machine and get the information immediately as we need it. Point of care ultrasound is involved with what is crudely basic and practical. It can describe something that deals with the most basic and practical aspects of an emergency situation. The purpose of POCUS is used to answer specific questions that can help confirm or rule out a suspected diagnosis, narrow the differential, or guide a procedure. Traditional ultrasound assesses an anatomical region using predefined parameters and measurements to provide a diagnosis. This is in stark contrast to the EFAST scan used for point-of-care ultrasound. In most instances, an EMS personnel or a physician who has had training with ultrasound, especially fast ultrasound for trauma, is going to have the ability to get the information they need. They don't go to traditional school to learn the physics of how the equipment works, what the Doppler effect is, and on and on and on. They're just taking a quick look to help them make a diagnosis. The point of care ultrasound, or POCUS, is more user-friendly and can be performed by any POCUS-trained clinician. There are special schools and certifications to get training and certified in this process. This certification certainly does not qualify you to be a sonographer. It is a very limited, specific focus program. The qualifications to interpret an EFAST extended focus assessment with sonography in trauma ultrasound test includes formal training, practical experience, competency, credentialing, and certifications. Unlike a comprehensive ultrasound examination, POCUS focuses on answering a very specific question. It examines only a particular area of the body or organ. They are also generally performed by the same clinician who has assisted or asked the specific question about the patient. This type of examination can take place in an emergency room or off-site. We use this type of exam for emergency triage. It is used by physicians, paramedics, and first responders. It is often used in trauma and in disaster relief. Ultrasound is one of the few modalities that is light enough and easy enough to take onto the battlefield and get immediate feedback for our wounded soldiers. It is also a critical tool for first responders and paramedics. Here we see a very small portable unit that is being employed by the paramedic firefighters on a trauma scene, probably a large auto accident, and one of the patients has been seriously injured. These small portable units can be utilized by trained paramedics both on the ground, in the air, or on site. Let's take a moment and just look at a complete overview of a fast ultrasound exam.
We will describe the basic principles. The primary aim of a fast scan is to identify major lacerations or injuries to the abdominal viscera and to identify any free fluid, which is assumed to be blood in the acute trauma setting. We start this examination by briefly looking through the liver and the right kidney. We are also looking for free fluid. Free fluid will be seen in the hepatorenal recess or in the subphrenic space. We also store a representative image. We will now move on to the left upper quadrant. First, we will inspect the spleen for signs of laceration, and then the left kidney. In particular, we are also looking in the splenorenal recess and in the subphrenic space for free fluid. Another representative image is stored at this point. Now we move on to the pericardial space. We need to change our depth to optimize our image. This subcostal view allows us to identify a pericardial effusion. A pericardial effusion collects between the layers of pericardium. If the effusion is particularly large, this can compress upon the heart and cause cardiac tamponade. We now examine the pelvis, looking for signs of bladder rupture. Intra-abdominal free fluid will often collect posterior to the bladder. In males, this space is known as the rectovesical pouch, as shown in this example. In females, this space is known as the rectouterine pouch, or pouch of Douglas.
As you've already deduced, there are quite a number of machines out there, different ultrasound machines of different sizes. Some are as small as a cell phone, some are a little bit larger. It depends on the area you're working and what you're working with. There are specific units that they use in the military, others for using in flight or for paramedics on site. There are others that are used in the emergency room. Each one is specifically designed to be used in the environment that it's housed in. Emergency ultrasound takes more than knowledge. It takes practice and skill. Each practitioner of emergency ultrasound needs to be mentored until they are confident in what they're doing. Emergency ultrasound can be broken down into two different categories. The first is the multiple targeted ultrasound examinations, and the second is a single targeted ultrasound examination. The more experience you gain, the more you understand the different things that you can look for in trauma. There is a difference, for instance, between normal tissue and tissue that has swelling or edema. Soft tissue edema looks different than normal tissue on ultrasound. Point-of-care ultrasound has been a practice-changing technology for the care of emergent and critically ill patients. This means that we're always expanding out what we can actually see utilizing this approach. The sonographer will be looking for cardiac findings, inferior vena cava findings, lung findings, abdominal findings, and other findings such as bleeding. Many times the person that requests the exam is the person that is performing the exam. This means they know what they're looking for and how to be able to demonstrate it. For example, an OB/GYN and an ER specialist are two different specialties, but both of them can use point-of-care ultrasound. Guess which one they do better at. The basic study for the emergency room is called the FAST scan, and we've now expanded it out to eFAST to include the lungs where they need to be if there is trauma in that area. The FAST scan can be effectively performed with limited scanning planes, since the object is to find free fluid and not do a comprehensive survey of all the involved organs. This approach makes the FAST exam easier to learn and less time-consuming. Do you remember an X-ray when you learned that you're looking for air fluid levels, that the person had to lie down supine or to roll up into a decubitus view, and you had to give time for the air to rise and the fluid to fall? This is the same thing in trauma ultrasound, but usually the patient is supine to begin with. Normal findings show regular anatomy and no intraperitoneal or intrathoracic fluids. We also look for lung sliding signs that should be present in a normal lung. Here we see COVID as it's demonstrated, we also see a demonstration of a tension pneumothorax. Working in trauma, we don't want to see either of those, but what we do want to see is the normal chest. Remember, if it's not normal, it's abnormal. Now it's time to take a look at some of the anatomy and what we see when we do a FAST scan or an EFAST scan. We'll start by looking at the lungs, and we want to see normal pleura. These two images show normal. The M mode image shows what we call the beach appearance, and it should look like sand and waves, and that's a normal lung. Prior to switching to the M mode to see the beach, we were using the normal mode. And in the normal mode, what we're looking at, the transducer shows us sliding pleura, which kind of looks like ants marching along a shelf. Looking at a normal chest or lung, what we see here is a normal pleural line and a right rib. Kind of looks like ants walking on the pleural line. Remember what we said? To the right, we see a normal comet tail artifact. If this artifact is not visible, you'll need to switch to M mode to take a look in M mode to see if the lungs are normal. To the left, we see a normal M mode lung. You see the beach, you see the waves. But let's say we see something like we see on the right. Not the waves, but lines. That is indicative of a pneumothorax. For the resident in ER or the physician in ER, when they're looking at lung x-rays, they can also do ultrasound. And here we see the difference between an M mode, where we have the beach and the waves, and we have a normal lung. Conversely, to the far right, we don't see waves, we see lines. This is a pneumothorax. That's why I say it takes some time and experience to become competent doing fast scans in the emergency room. The clinician in advanced trauma life support should start with a primary survey: airway, breathing, circulation, disability, and exposure. The EFAST scan is a secondary survey, and it does a complete physical exam using ultrasound at the bedside. Remember, this is a specialized study looking for specific areas for quick diagnosis. It is not a comprehensive type of exam. We'll begin by looking at the transducer placement on the FAST scan and then move into more specific anatomy that is demonstrated in each one of the positions. This is a sub-xiphoid view that allows us to see all four chambers of the heart. We then move to the right upper quadrant view, where we're able to see the liver, the lung, and the right kidney. Notice we do both sides, so when we do the right side, we're able to see the liver, but on the left side, we're able to see the spleen. Then we take a quick look at the bladder and see what we have there. Now we'll look at some patients with some pathology. Hemorrhage due to blunt trauma and penetrating trauma is a common cause of morbidity and mortality among acutely injured patients. The FAST scan allows us to look for hemorrhage. The rapid assessment and diagnosis of injuries in trauma patients is often challenging due to the altered mental status and distracting injuries that the patients have. Focused assessment with sonography for trauma, or FAST, is a screening tool to identify free intrathoracic fluid, intraperitoneal fluid, and pericardial effusion and pneumothorax in trauma patients. There usually needs to be more than 400 milliliters of fluid to be able to visualize it on ultrasound. Also, if you do visualize the fluid, you may not be able to see where it is specifically coming from. Here we can take a look at a right upper quadrant view. This shows us the liver, diaphragm, and kidney. Notice below that we have blood inside what is called Morrison's pouch. Now we'll take a look in the pelvis at the bladder. Notice at the top it's normal. At the bottom we have blood filling the bladder. Now we'll take the subxiphoid view. The subxiphoid view is for seeing the heart. Notice at top there are the 4 chambers of the heart, whereas on the bottom what we see is pericardial effusion or fluid around the heart. So here you can see that you can get good images even with a small handheld ultrasound unit that you might use for a trauma assessment. Here we're looking again at the subxiphoid view for the cardia or the heart. Basically, this is a fast and easy exam to do. It shouldn't take you as long as it took to get through this entire presentation. In fact, we might have been able to do the exam 2 or 3 times during this time period. But of course, we are explaining it to you here. So with that, I'll say thanks for your attention and thanks for your time, and we'll see you next time. This is Mark Struthers.